Good morning, good afternoon, good evening, everyone. Welcome to the SIOG Lymphoma in older adult research and treatment options in the COVID era webinar. This webinar will be chaired by Dr. Novak and myself. And we have an exciting program, and 4 panelists are going to give you some very nicely up-to-date information on lymphoma in older patients in these challenging times. Couple of practical points. If you want to ask questions, we will answer the question at the end of the webinar. And meanwhile, you can ask the question in the Q&A box. The chat box is only for technical questions. The question and answer is the one that we are going to look at to select the questions at the end. And this is where you can do any technical question. The SIOG head office can answer you in the chat box, and we'll be glad to help you in the best ways we can. Without further ado, let's go to our program. The first speaker will be Dr. Matti Apro, who probably anybody in the geriatric oncology world does not need to have Matti introduced to them. Matti Apro has been interested in geriatric oncology since at least as long as I have, and he was actually my attending physician when I was a fellow way back then. So Matti has a lot of familiarity with geriatric oncology. He is a board member at the Clinique of Genolier, has been president of MASC and on the executive board of the RTC, and will right now tell us about general consideration when treating lymphoma in older patients. Matti?
Thank you very much, Martine, for your introduction, and remind me that I'm slightly older than you are. So this is indeed where I work. It's in Switzerland. There's the Genolier Cancer Center. And what I was asked to say is called general considerations. I transformed that into a few key messages in the next 8 minutes. My conflicts of interest are on this slide. As I always say, I have enough of them to have none. And I have to also declare the fact that I'm the president of the European Cancer Organization right now. And I'm delighted that SIOG is a member of the European Cancer Organization. The input of SIOG to various of what we call the focus topic networks of the European Cancer Organization is extremely important, because this really allows those that fight for the rights of the senior citizens, to use American wording, to be there and make it clear that they should be at the forefront. We know, you all know, that patients beyond a certain age represent a sizable majority of cancer patients in Europe. I'll go through a few areas in this introduction, which I believe are very important for the background of the superb information that we'll hear from experts of different types of lymphomas, different areas in lymphoma. But before I go there, I would like to remind the voice of the patient. And the voice of the patient says what we all say, that whatever we discuss, it's about a patient, it's about a person that might or might not have other diseases than the lymphoma, and that it is not the age of the patient that counts, is who the patient is that counts in the decision-making process. A key point is diagnosis. And why do I say that? It's because of the little experience I have with lymphoma, but also with other diseases, where unfortunately we see patients coming without a proper diagnosis. And one of the points of proper diagnosis in all cancer areas is to make sure that your hematopathology lab has experience. Do not rely on a diagnosis from a hematopathology lab that sees a few patients with lymphoma every year. That will not allow you to be certain of what is going on And you all know that in this area and many others in oncology, we need to be very precise because that changes completely the approach and what we can do. And outside of clinical trials, by heaven's sake, in elderly patients, do not stage them as they would be staged in a trial. Think of the patient first. What is really useful? Do you really need to proceed with this or that staging procedure before you decide to discuss that with the patient? Some issues that all elderly patients face and which are relevant for the lymphoma question also. And one of them in hematopathology is, well, for that old patient has a little bit of anemia, it's okay. No, it's not okay. It's not okay because anemic patients are patients that have something that leads them to be anemic. Might not be the lymphoma, might be something else. So we have to find out what it is. Then there's another very frequent issue in the elderly that we will encounter in our lymphoma patient, and that is malnutrition. And malnutrition is prevalent even in rich Switzerland, as Martine so well knows, as many of the speakers know. Unfortunately, patients that are in so-called protected homes are malnourished. Those that are lived by themselves are maybe a little bit malnourished. Those that live fortunately with someone else are not as malnourished. And malnutrition is an issue. It is an issue that has been discussed by many. Here's a paper that Maurizio Muscaritoli and Jan Arends wrote with me as a third author, which has been completely superseded by what is going to be very soon published by the ESPEN Practical Guideline Nutrition in Cancer Patients in Clinical Nutrition 2021. It is already in part downloadable from the ESPEN website, and the Jan Arends-led ESMO Clinical Practice Guideline that will soon be on the ESMO website and published by ESMO Open has been accepted for publication. So how to evaluate these patients? Just a little word for all of you. You all know, but tell to all your colleagues that someone who's 75 years old, here's the case of a male patient with no special comorbidities, has a certain life expectancy. Is it 5? Is it 9? Is it 14 years? Well, you have it here. It is 14 years. Still valid. Data from a long time ago, still valid today in our areas. This might not be true for those of you who are looking at us, listening to us in other areas of the world, because unfortunately the situation of older people means that they are not in the same physical fitness situation as the so-called standard European. We can evaluate them in a more precise way using different tools. One of them that we always have promoted is the GA Geriatric Screening Tool. And I have highlighted here that in red we have questions that are pertinent to nutrition. It's a fast test, it's an easy one, it's not ideal by any means, but it helps. It helps in giving some prognosis to these patients outside of the question of the tumor. And we know that these patients are very different. Some of them are like here, risking their life. They are going to soon break because that lady is going to fall, this gentleman is going to fall, but nevertheless, they are certainly fit. All of the question of how to assess these patients was a wonderful series of presentations at ASCO of last year. And Enrique Soto Perez de Celis, a prominent member of SIOG, along with Hyman Mas and myself, wrote a summary of these wonderful papers in the oncology, freely downloadable for all of you. I will not insist on that at this point in time. But assessing fitness, and I'm using here a slide that some of you might have already seen, which I love, given to me a long time ago by Ricardo Audesio. We know that these two animals here are fit. Only one of them is doing something that is absolutely not possible. So fitness is not meaning that the elderly patient is going to be able to tolerate, for example, chemotherapy. And you have two tools that are somewhat useful. The one developed by R.T. Hurrier, and I put here forward creatinine clearance, not the creatinine value in the blood, and also in Martin Exterman's tool, the creatinine clearance. And this one has also a very nice downloadable tool in the Moffitt website. And another issue, very relevant for some of the drugs you use in lymphoma, is polypharmacy. Never forget it. if you forget it, the patients might have side effects that you don't want them to have. And now to the theme of today, COVID. We do have some guidance. It is not perfect by any means because we are learning. We are learning as things go on to understand how to adapt our treatments, how to go forward. I must say that the European Society of Medical Oncology has done fabulous work. They came out with some adaptations of all the guidelines for the situation of COVID. Here's one about supportive care, the use of GCSF, which is so important in the treatment of some of our lymphoma patients. And they have many other indications that you can find on the ESMO website. Also, for those of you that are hemato-oncologists, and for all of us, go to the EHA, European Hematology Association website. Lots of questions are being answered there, and they will adapt these answers as we learn more and more about what is going on. And of course, your society, SIOG, I hope you're all members. If you're not, become members of SIOG, has very quickly reacted, and there's a wonderful paper available for you in the Journal of Geriatric Oncology, downloadable on our website, about how to adapt to the COVID situation. And a last word for COVID: vaccinate, vaccinate, and vaccinate. Don't listen to those that are propagating all kinds of fake news about this and that and so on about vaccinations. We know that for many of our hemato-oncology patients, they might be less effective. We have known that for a long time for flu vaccine, but still it is much better to vaccinate than not to vaccinate our patients. And we can discuss this further in the question and answer if you wish. So with this, I'd like to conclude, welcoming you all to become members of SIOG. SIOG has many guidelines available to you, and many are going to be presented now. We also have teaching. The SIOG Advanced course is going to be from December 15th to 18th in Treviso in Italy, hopefully face-to-face. And of course, we are going to have before that a wonderful meeting in Geneva. Most probably it's going to be only through the web, but let's see, maybe things will change for the better in the next few weeks and months. So thank you very much for having listened to me. This was an introduction to now much more scientific talks. Thank you.
So thank you very much for both of the previous speakers, Martin as the co-chair and Matti Opro, who gave a nice introduction on general issues for the elderly population. And I think we should now go to lymphoma entities. So as people of you know, lymphoma entities are various. They start from indolent lymphomas that have their special issues, and will also include aggressive lymphomas. And we will start with the indolent lymphomas, and the presentation on these indolent lymphomas and issues with regard to COVID will be given by Emanuele Zucca, that is a medical oncologist from Bellinzona here in Switzerland. Please, Emanuele.
Thank you, first of all, to Matti and Martin for inviting me to give this talk. I would speak mainly of indolent lymphomas in older adults. You can see in this slide some data, some epidemiologic data on lymphomas, on indolent lymphoma. On the left, you see UK data, and you can see how the overall, the main lymphoma subtypes have a growing incidence over the time being in our entire life. Some of them have a plateau, but others are still growing after the age of 60 or 70. And the two most common indolent lymphoma, follicular lymphoma and marginal zone lymphoma, because of their nowadays expected very long survival, approximately of 20 years from diagnosis, then the prevalence of patients with this type of lymphoma in the population is also continuously growing. And on the left, we have Swiss data on the CLL incidence. CLL is just the leukemic counterpart of an indolent lymphoma, small lymphocytic lymphoma. They both are the same entity. And again, you see there is a continuous increase of incidence at an increase of age. So indolent lymphoma, to make a short story, is a disease of elderly. More than half of the patients with indolent lymphoma are over 70. Indeed, median age is between 65 and 70 for follicular marginal zone lymphomas, and is 70 or over for chronic lymphatic leukemia. These are the data published now some months ago on Lancet from an epidemiological study by UK colleagues comparing a tumor registry cohort with nearly 300,000 cancer patients and a smaller cohort of about 1,000 of cancer patients with COVID infection. And they found that there are particular types of cancer at a higher risk of developing COVID infection, and hematological cancers such as lymphoma are those with the highest risk of getting infection by COVID. This again, especially for indolent lymphoma, is something also associated with the prevalence of elderly people and the immunosuppression, which is a typical aspect of many lymphomas. And you see that the mortality of COVID in this cohort is increasing over the age of the patients. Patients with hematological malignancies were at higher risk of having a more severe COVID infection and to require more often intensive supportive intervention. They had more frequently for the hematological patient, they had more frequently intensive care unit admission, and actually the fatality rate was higher for them. And this slide, to finish this introduction, is again showing that whilst CLL or small lymphocytic lymphoma has clinical features that are very similar to those of patients with COVID-19 or patients with high risk of getting COVID-19, age, immunodeficiency, and comorbidities. The recent data are pointing out that some patients with indolent lymphoma have a clearly higher risk of developing a critical form of COVID-19 with a mortality rate which is much higher than the rest of cancer patients or the rest of the COVID-infected population. So I would now start with the discussion of some of the questions, some of the FAQ, the most frequently asked questions. I don't pronounce it as a word because it can have a bizarre sound. And which COVID screening procedure should we apply in elderly patients with indolent lymphoma? Basically, treatment for indolent lymphoma is not curative. The disease is waxing and waning, and they can have multiple lines of therapy, and ultimately they may die for other reasons than the disease or for the disease itself. But this indolent course gives us much more flexibility in screening approaches when compared with aggressive lymphomas or leukemia in need of immediate life salvage treatment. And in elderly patients with indolent lymphoma, we should have a particular focus on safety. Most centers are screening patients at the beginning of therapy when they are treated as an outpatient clinic or on an ongoing basis, or just only before admitting them to the hospital. Practice are differing depending on COVID-19 prevalence and test availability in different countries and in different institutions. We test asymptomatic patients with an RT-PCR swab 1 to sometimes 3 days if the visit is planned on Monday before starting therapy or hospitalization. And we do regular phone interview to rule out COVID-19 symptoms before outpatient visits. Second question is, should elderly patients with indolent lymphoma receive vaccination? Answer has already been given by Matti. Give it vaccination. Vaccination and vaccination. COVID-19 vaccine is appropriate and safe even for patients who have underlying severe health condition, perhaps with the rare exception of some of those with an history of allergic reaction. There are very scarce specific data on safety and efficacy in the immunocompromised patient. However, there is no evidence that the vaccination will have any impact on lymphoma therapy, neither on inducing an increased risk of side effect for cancer patients, and particularly for lymphoma patients, which are a subset of patients with a particularly compromised immune system. Therefore, we recommend to do vaccination in elderly people with lymphoma, even if you may believe the response would not be optimal. Vaccination time must be individualized and based on prevalence of COVID in the community, patient and family member and caregivers' capacity to self-isolate, expected duration of lymphoma therapy, and of course, availability of vaccine. And the priorities set by each country are, of course, coming before any of our desire of vaccinating everybody as soon as possible. Now, does SARS-CoV-2 vaccination works in patients receiving rituximab? Rituximab is killing all B cells with no exception. So the capacity to mount an antibody response is expected to be reduced. However, the extent of impact from rituximab on response to COVID-19 vaccination is poorly known. We have said that it is expected to eliminate a humoral response for at least 3 or more months after the last exposure. T-cell responses, however, are important and may provide some degree of protection or reduce the severity of infection. This justifies vaccination even during or anyway soon after rituximab treatment. Vaccination also of family members and caregivers is theoretically recommended. This is not everywhere possible. Another frequently asked question is whether we have changed the indication for treating indolent lymphomas. The threshold for initiating therapy during the pandemic must be higher, in my opinion. And we should watch and wait patient whenever possible. The purpose should be to treat only symptomatic patient. Rituximab monotherapy in asymptomatic patient, it was a very common approach, but now is not recommended. You can wait and see until pandemic is finished. And also, when the indication is borderline, for example, in a follicular lymphoma patient who is, let's say, having some of the GELF criteria for starting therapy, for example, anemia or pancytopenia or B symptoms. But the symptoms are not very important. This patient should be considered for a deferral of therapy and close monitoring as much as possible. Of course, when we plan to start therapy, we can wait a little bit. We should do vaccination first. Also, we should give vaccination against the flu and pneumonia in patients that we plan to treat for lymphoma, because the risk of side effects is also higher. And of concomitant infection, they may be a complication of COVID and of lymphoma treatment. Should we change our therapies? Yes, we can reduce the number of cycles or switch to less immunosuppressive or myelosuppressive approaches in elderly patients who have already achieved a good response to induction chemotherapy or immunochemotherapy. Again, treatment is most often not curative. So once achieved a good disease control and the patient is completely asymptomatic, you can decide to stop therapy. Maintenance rituximab is still prescribed by some of the experts. We are not giving routine maintenance at least until we will not see a vaccination of all our indolent lymphoma patients. And perhaps with the exception of some patients receiving maintenance in a randomized clinical trial. Should we change also the schedule of our visits? We can delay visit.
Dr. Suka, we are hitting time limits, but please.
Yes, I will finish in 2 minutes.
No
we
problem.
can change, we can reduce the visit. We can obtain lab work by family physician. We can consider telemedicine. And we also could change supportive care, should change supportive care, again, giving proper antibiotic and G-CSF support for patients under therapy. As pointed out before, we can also give with more liberal decision immunoglobulin supplementation. We can not use bendamustine because it's very immunosuppressive whenever possible. We can switch to oral treatment using, for example, BTK inhibitors and lenalidomide without rituximab. Some similar data have been provided in a review by Davide Rossi and colleagues for the management of CLL, published by the Hematology European Hematology Association new journal, Hemasphere, a few months ago. And also the ILROG, the International Group for Radiotherapy in Lymphoma, has provided some guidelines for reducing the demand of radiotherapy during pandemics in patients with indolent lymphoma. You can either omit radiotherapy, delay it, or shorten it it occurs according to the individual patient necessities, and in fact, I can stop with this simple final conclusion. Thank you for your attention. The take-home message is that indolent lymphoma are an elderly disease, and elderly people should be protected first from COVID risk, and then you can treat a lymphoma, which is usually a chronic disease where treatment is most often non-curative. Thank you again, and I hope I finish in time.
Okay, thank you very much, Dr. Zucker. For those who want, SIOG will also make available our slides after the webinar so that you can look at all the information that Dr. Zucker gave us and more details and find the references on his talks. Our next speaker is Dr. Christophylakis. And Dr. Christophylakis is a faculty at the Saarland University Hospital in Germany. And he's going to talk to us about aggressive lymphomas.
Yes, thank you, Ms. Hexerman, for the kind introduction and the honorary invitation. I will not talk about supporting measures in regard of the COVID pandemic because they were adequately covered in the excellent talk before me, but I will go on with aggressive lymphoma and I will focus on diffuse large B-cell lymphoma in the interest of time. I'm having a small trouble with my screen, but I think if you give me one moment. Okay, so, and I will start with risk stratification in the rituximab era. And we have seen in recent publication this year that from the many prognostic scores that we have, the NCCN IPI can most adequately predict prognosis for our patients with diffuse large B-cell lymphoma, and it does so by adjusting for age and LDH levels. But what it cannot do is define a group with a clearly dismal prognosis below 50% of overall survival. But a score that can do that is one which incorporates a geriatric assessment, a simplified comprehensive geriatric assessment developed by the Italian study group shown in the ESH meeting 2 years ago. And you can see on the bottom right of the slide that the incorporation of simplified geriatric assessment can identify a very fragile population with DLBCL. The different study groups have different definitions for risk stratification and treatment stratification, but we can, let's say, for the purpose of the talk, agree that we have low risk and high risk DLBCL, and starting with low risk DLBCL with no bulky disease. One approach is 3 cycles of air-CHOP with involved field radiotherapy. This has shown after long-term follow-up that relapses continue to happen, and in the end, there is no difference with 4 cycles of CHOP. Even the addition of rituximab to this strategy does not lead to a plateau with continued relapses, so that in most European centers, standard of care is are 6 cycles of air-CHOP as established in the RECOVER trial. But this may be change. This may change in the future based on interim PET-CT. Maybe we have the option for the escalation. And we have seen it in younger patients in the FLYER study, where 4 cycles of air-CHOP were adequate for low-risk patients. As the trial, American trial, which looked at patients across all age groups, found that patients who had a negative interim PET after 3 cycles of air-CHOP were adequately treated with 4 cycles, and similar results have been shown in the interim analysis of the optimal trial from the German study group, so that this may be a concept of the future. We await the results of the French LNH 2009 optimal trial until they're published. Six times R2 is the standard, most European centers, but de-escalation based on negative interim PET-CT may be something that one can consider in the COVID-19 pandemic, because there are data on it. What we do about bulk, we have seen that omitting bulk irradiation compromises survival in patients with DLBCL, so we wouldn't do that, but maybe not everybody needs to be irradiated. And we have seen in the interim analysis of the optimal trial that bulky disease, that when we only irradiate bulky disease, which is FTG positive, at end of treatment PET, we use 40% less radiotherapy without compromising outcomes. And we have seen published Canadian registry with similar results, who also irradiated only FTG positive bulky disease at end of treatment, and 2/3 of patients received no radiotherapy without compromising outcomes. So we will only irradiate PET positive bulky disease at end of treatment PET. Can we improve outcomes in high-risk diffuse large B-cell lymphoma in the elderly? Can we improve R-CHOP, the R-CHOP regimen? The answer is unfortunately no. We have tons of negative phase 3 trials. We have not been able to improve outcomes in this area, so that standard remains 6 to 8 cycles of R-CHOP. We use 6 cycles of R-CHOP 14 with KIT CSF because it's a shorter regimen. In the COVID pandemic, the patient has less contact with the hospital. What about frail patients with DLBCL? Well, we have seen from the study by Vicky Morrison, published last year in the JGO, that patients, even elderly patients, do much better if they are treated with R-CHOP regimens, and this is true also for patients aged above 75 years old. So we wouldn't go for non-R-CHOP regimes. The second question is, how much R-CHOP do we give our patients? And we know that when we try to do full dose R-CHOP at patients aged above 80 years, things go bad. They have worse survival. So standard of care for this population remains R-mini-CHOP. How about relapse refractory diffuse large B-cell lymphoma in patients who are transplant ineligible? We have 2 very interesting studies published last year. First, the addition of polatuzumab to rituximab bendamustine with an impressive improvement in overall survival of 8 months, some imbalance in the 2 treatment arms. And second, tafasitamab lenalidomide, not yet approved in Europe, but in USA, impressive overall survival curves, but asterisk, primary refractory DLBCL was excluded in this trial. However, promising results, less immunosuppression for our patients. What about CAR T-cell therapy, the new player in DLBCL? We have a third product which has been approved from the FDA last month. How about elderly patient CARs? We saw data in the past ASH from from the MD Anderson Fitzgerald, and we have a publication 2 months ago from Lynn, from Memorial Sloan Kettering Cancer. This data concern axi-cell and Tisa-cell. And you see on the left the curves, the survival curves for patients aged above 67 and younger patients. You see survival in the elderly is at least as good as in younger patients, although they have functional limitations and comorbidities. Toxicities are similar with slightly more immune effector cell associated neurotoxicity syndrome in the elderly patients. So we can conclude that this is a safe therapy for the elderly. What about CNS prophylaxis? We saw some contradictory data in the ASH. We have supported discussion in the lymphoma community. The first is a large retrospective trial from Canada, 1,000 patients, which showed that patients who were given intravenous methotrexate for CNS prophylaxis had the same rate of CNS relapse as patients who were not treated. And a second retrospective trial, again 1,000 patients, showed that prophylaxis CNS relapse did not differ as per prophylaxis route. So this has put the role of CNS prophylaxis into question. Maybe we should only treat high-risk patients. We should definitely adjust the dose of methotrexate for age, and maybe in doubt, don't treat elderly patients in the COVID-19 pandemic, but we can talk about more in the Q&A session if there's interest. And with that, I reach my final slide. These are my take-home messages. Maybe treatment de-escalation based on negative interim PET. I would give GET-CSF, and we should talk about CNS prophylaxis and omitting radiotherapy in PET-negative bulk. And thank you for your attention.
Thank you very much, Konstantinos. I'm sorry. So actually the next speaker will be Alden Mocha. You know, during the first wave of COVID in Switzerland, at least, the Ticino people, so Alden and also Emanuele, were the ones that we contacted from Bern because we were much less hit in Bern, at least in the first wave by the COVID. And then we usually contacted our colleagues what to do and how they actually we're trying to go through this COVID problem. So Alden will talk on Hodgkin lymphoma, and I hope maybe we can save some time with your talk for the Q&A. Thank you very much, Alden.
So thank you very much, Urban. So I try to share my screen. Sorry, I have some problem. Okay, I would like also to thank the organizer for giving me the chance to present this short presentation. Regarding Hodgkin lymphoma in older adult, I should start just saying it's a smaller population in comparison to the other non-Hodgkin subtypes, and approximately 20% of whole Hodgkin lymphoma patients are older than 60-year-old. There is currently no standard treatment for this particular population, mostly also because these particular patients are rarely included in clinical trial. In terms of outcome, if the outcome appear to be acceptable for patients with early stage disease, in general, it tend to be poor in comparison to the oldest youngest counterpart in patients with advanced stage disease. And this is particularly due to the presence of comorbidity, which may limit the therapeutic option, in particular the use of bleomycin or anthracyclines, and they also induce the patient to use lower dose of chemotherapy, which of course they may reduce in treatment efficacy. Clinical trial have also observed an increased rate of severe complication in this particular population, and when intensive regimen are used, a substantial increase in treatment-related mortality. Also, in terms of clinical presentation and biology, we do see several differences in terms of young and older patients. Older patients, they tend to have a more advanced disease diagnosis. They present typically with a higher proportion of patients with a poor performance status. And from the biological point of view, the mixed cellularity tend to be more present in the oldest population. When we look at the outcome of patients with Hodgkin lymphoma over the past 50 years, what we can observe that there has been a substantial improvement in the outcome, but which was particularly true for the youngest population. We have seen an improvement also in the outcome of older patients, but with less importance. Regarding Switzerland, we have an analysis which was conducted in the last few years, and also in Switzerland, in this unselected population treated in referral center, we could observe a substantial decrease in co-specific survival, in particular in patients older than 70. As said, there was not a standard treatment for older patients with Hodgkin lymphoma. On this table are summarized the most used and historical chemotherapy which have been tested in this particular population, you can observe that the number of patients included in this trial is quite limited. The outcome is by far inferior in comparison to the data we are in general do see for the youngest population, and that the treatment-related mortality appear to be also very high, in particular when intensive regimen like BCOP baseline were used. BCOP, which is in general, it's based on these results, not recommended for this population. There has been several alternative approaches which have been investigated, in particular with the implementation and the use of new compounds. In this case, the immunoconjugate brentuximab vedotin was used sequentially together with an ABVD backbone with the omission of bleomycin, and this approach appeared to be feasible, quite well tolerated, and with very promising results also in terms of efficacy. Another class of compound now used and now being tested in first line are, of course, the checkpoint inhibitor. And in this preliminary trial, in a limited number of patients, the combination of nivolumab together with an MVD backbone appear to be feasible, fairly well tolerated, and the response and the disease control appear to be very promising. There has been several algorithms which have been proposed for older patients with Hodgkin lymphoma. Of course, for patients with early stage disease, in general, those patients are treated with combined modality therapy, so few cycles of chemotherapy and radiation. And in general, also older patients, the majority of older patients, they may tolerate a limited number of cycles of chemotherapy. For patients with advanced stage disease, of course, we should determine whether the patient is fit enough to be treated with a more intensive combination for a longer period of time and with a curative intent, or for patients with many comorbidity to consider to use more simplified regimen, for example, CLEBAP based on alkylator or single agent chemotherapy. For the use of bleomycin, which one of the key components of the ABVD combination, also appear to be problematic in older patients, in particular when it's given for more than 2 cycles. And this was well shown by the German group. In patients treated with 4 cycles of ABVD, the incidence of bleomycin lung toxicity was in the range of 10%, which was, of course, extremely high in comparison to the 2% of patients treated with only 2 cycles. So we come back to the COVID-19, and we all know that the COVID-19 mortality is related to the age, of the patient, but it's also related to the fact that a patient has a comorbidity or the presence of hematological malignancies. And this was well demonstrated in this very recent analysis, which was conducted last year in Italy. And when we look at the different type of hematological malignancy, we do see that Hodgkin lymphoma is a minority of those patients, but still patients with Hodgkin lymphoma and COVID-19 infection, they appear to have a higher risk of death in comparison to the reference. So we have different guidelines which are proposed by the Principal Society regarding how we should manage patients with Hodgkin lymphoma during the COVID-19 here. It should be underlined the fact that for Hodgkin lymphoma, the consensus among panelists of the ASH were higher in comparison to other type of lymphoma. The treatment approach has not been impacted significantly for Hodgkin. We have a general recommendation regarding vaccination we have already discussed in the previous presentation. And again, whenever possible, we should proceed with telehealth or phone call in order to reduce the number of visits in the hospital. For patients with early stage disease, we have seen that those patients are classically treated with combined modality therapy, so a short course of chemotherapy followed by radiation. In general, for elderly patients, the expert from ASH, they recommend to omit bleomycin and to consider to use growth factor. And for radiation therapy, we have alternative dose fractionation, which have been proposed by the ILROC, so the International Lymphoma Radiation Oncology Group. Regarding the ESMO recommendation, there are very general and very similar recommendation in comparison to the ASH recommendation. We have essentially the idea to use a less myelosuppressive regimen and to consider GCSF, and again to try to prioritize the use of phone call and telemedicine. So regarding advanced stage Hodgkin, we have seen in older population in this COVID era, the ASH recommendation are to, whenever possible, to omit bleomycin and to consider to use more frequently GCSF, in particular when patient, and this is the case mostly in North America, where brentuximab is given together with AVD, as in the Echelon-1 trial. Some experts also recommend to prescribe prophylactic antibiotics, in particular for neutropenic patients. And in the relapse setting, in general, of course, we are faced with a very heterogeneous population. Some patients are treated with a curative intent, and for those patients, the recommendations are regarding, whenever possible, outpatient second-line regimen based on gemcitabine, like GDP, and for other patients, and when available, to consider to use new compounds like brentuximab vedotin or anti-PD-1 antibody. So to conclude, would like to highlight the fact that there is still no standard treatment for elderly patients with Hodgkin lymphoma, and this particular group of patients should be studied, investigated more in detail in prospectively clinical trial. For the COVID-19 era, in general, we have recommendations which are more focused on the omission of bleomycin and the use of GCSF, but the treatment approach has not been impacted significantly. So thank you for your attention. I will be happy to take any question if there are any.
So thank you very much, Alden, and also a big thank you to all the previous speakers. So it is now my task a little bit to moderate the questions from the audience. I have seen so far an immense amount of one question, and I think this is not probably what you have, because of course the pandemic has much more, how can I say, raised much more questions than answers, I would like to say. Maybe if I quickly summarize, you have seen that lymphoma is a vast variation of diseases coming from indolent diseases, as Emanuele has pointed out. And then we have seen, how can I say, aggressive lymphomas that have different issues. There the goal is somehow cure, and you have to try to maybe adjust the treatment a little bit if you can, according to the threats by the COVID. And then Alden has pointed out to Hodgkin's, which is in older patients a rare disease, and there's no standard treatment before. And I just reminded you that we have also learned a little bit during the COVID when it started a year ago. I remember we had a workshop in Switzerland that was actually has attracted a lot of interest. At that time, we had struggled with all these ESMO guidances to how can we adapt omit day 8, do this and do that. And I think since then, the evidence has not really increased a lot. We still don't know what to do. And in the meantime, I think we have much less COVID, at least in Switzerland, and the vaccinations are now the key questions, what to do, when to do, and then availability that has pointed out by Emanuele that may be a particular issue at the moment in Switzerland and may be very different in Germany, where Konstantinos is working, and may also be different now in the States where Martin is working. So a lot of difference. And I think when I look back to let's say, when the COVID started in Switzerland, the biggest threat at that time was not only the lack of guidance and the lack of knowledge, but at that time the potential exposure to COVID-19. So it was included travel and waiting rooms, of course, that you should avoid, and not only treatment. And at that time also there were concerns about treatment delays or dose reductions that actually put our patients with lymphomas to increased risk. And I would like to say also a statement that limiting duration of neutropenia and the risk for infections has always been a good idea and is definitely not an invention of COVID pandemia. So, and I think at least in Bern we can prove this very nicely, that there was, of course, a beneficial awareness for infections and hygiene measures. And I think this is something that the patients profited during the pandemic, and I think they will also profit when the pandemic will be over, because I think it has completely changed our awareness of infections. So if I go to questions that were asked, there was one question that was by Mr. or Mrs. Betts, and he or she was asking whether it is the data is considered sufficiently robust at this point to recommend no radiotherapy to PET negative bulk in diffuse large B, or this is something that is an invention by COVID. Konstantinos has eloquently answered this question, and I would like to add not only to the published data, but also like to point your interest in a meta-analysis that we did, including all randomized trials. These were 11, actually 3 have been retracted later, but this is a very clear evidence that you can do that. So there's actually no way of doing, or no need of doing radiotherapy for PET negative, even bulky disease at this point. So this is something that I think you can safely do, and COVID has not really changed that. There was another question, if I say, it was by Ulrich Wedding from Jena, and he was asking how you define frailty in patients with diffuse large B. So I think this is a question I think our specialist Martin should actually answer. Martin, we can't hear you. We still can't hear you.
Should I?
Or maybe someone else? Alden, or Alden, would you like to answer this question, or Konstantinos? I don't know. Anybody? Alden, would you like to answer?
So, well, I'm not an expert in geriatric oncologist, but we have several tools which have been described, and they have also been partially validated in clinical trials. Essentially, they are based on the presence of comorbidities, like the SEER scores, and other scores. They evaluate the daily activity, like the ADL. So unfortunately, the information regarding this score in the clinical practice and regarding the use of specific regimen based on the frailty is still quite rare in the literature. But I think the future trial aiming to include in this particular population, they should use, they should consider to stratify the patient also according to these particularly specific tools.
Okay, so this question is not really related to COVID, but let's say anyway, how to define frailty. And as Konstantinos has actually pointed out very nicely, in this particular case, you can use maybe mini chop as opposed to a full dose chop. We have.
Sorry, yeah, sorry, my
okay.
frozen me.
Would you like to add something, Martin?
Yeah. So there are several studies that have tried to look at frailty in aggressive lymphomas, and they have used the kind of what we call Balducci-like index. Our colleagues from Italy have done several studies like that, and this is essentially what Dr. Christoflakis was showing in one of his slides with large cell lymphoma: the presence of ADL dependence, the presence of comorbidities, severe comorbidities, eventually a higher age, and the presence of the geriatric syndrome. So I think there is literature to support that particular definition of frailty. There is a little less literature about how to adapt treatment to it. But it's a good stratification of patients. It's a bit like the EPI slide that you presented.
Thank you very much. Then we have 3 questions from Dominique Bron. She asked the question that I would like to maybe hand over to Emanuele. So the question is, I guess this relates to any lymphoma patients that we treat with, let's say, ibrutinib or venetoclax. And the question is, should you stop ibrutinib or venetoclax before or after COVID-19 vaccination? What would you say?
Actually, we do not know very well if there are interactions between treatment and vaccination. But what I am doing is stopping any therapy for a couple of days before and after vaccination. Then I start again with therapies which are not like the ibrutinib example, which are not impairing dramatically the immune system. Anyway, the question would be relevant with rituximab, but I spoke enough about it before. If a patient is deemed to need rituximab therapy, we would do vaccination anyway, as we did previously with flu vaccination or pneumonia vaccination in immunocompromised patients. And what we are doing actually, this is a larger issue, and perhaps Urban, you would also comment on this, is trying to wait at least a couple of months after transplantation and CAR-T to have all the best possible effect of vaccination, and with CAR-T also not to interfere with a potentially curative process. This was, together with my answer, a question for Urban.
Yeah, so if I, it's very nice. So the recommendation, let's say, of the CAR-T that we are using in Bern is to, how can I say, to vaccinate 3 months after CAR-T. So this is, you know, as you pointed out, so with rituximab, you kill the T cells, the B cells, and with, let's say, the lymphodepleting chemotherapy, before you also, let's say, kill to some extent the T cell response. So that's why it's not that we don't want to do it, but I think we have no one at the moment has an idea when to do. But the recommendation is to wait 3 months. Otherwise, it is sort of a waste. Ideally, and this is something that we have done in Bern, since we have approached the government to be able to vaccinate the patients by the need, that because they have been planned treatment with CAR-T, so we can do it before at least 1 dose. However, don't forget, these patients, many of them have received a chemotherapy before, be it the bridging chemotherapy, and we have so far, we have results from 3 or 4 patients, and none of them, even after 2 vaccinations, which is the best what you can get in this short period of time, has had any antibodies after that. So this is a very difficult issue. I can see a lot of questions coming to the time point of vaccine, and maybe if I try to summarize it a little bit, what we need is data, not just expert opinions that we had, I think, enough in the last year. And maybe the question a little bit to the others is that are you also participating in vaccination trials? Because I think this is a very important answer to these burning questions.
So Moffitt has a trial of taking antibody levels in cancer patients with who get in vaccination. So we should have an answer from that.
Yeah, we would also try to participate at the European how can I say, European trial to try to address this point. I think Matti wanted to ask or has risen his hand.
No, indeed, I had raised my hand before, but I think that has been very nicely answered by Martin. I would just like to insist about the evaluation of the elderly people. Why did I mention nutrition and I didn't mention in detail sarcopenia? So there's a clear relationship between creatinine clearance, the way we measure it, and we mistakenly measure it, and the fact that sarcopenia relates to the increased toxicity of many of the drugs we have. So this is something that we really need to start thinking about and put forward in some of our protocols. Now, there are many protocols ongoing about measurement in the setting of our patients. I think many university hospitals are doing that. Lausanne University is doing that. We unfortunately, generally, are unable to participate for logistical reasons, thanks to the Swiss health authority system.
Okay. Maybe I look at the watch. We are 5 minutes past. Maybe we do some 5 more minutes before we conclude. Martin, is this okay for you?
That's okay with me. I think the audience looks interested. I'm seeing more questions coming in.
What are the other questions?
For the timing of vaccination during chemotherapy,
yeah.
Also CHOP has 5 days of high-dose steroids. You don't want to give the vaccine on day 1. So typically we try to do it between. Yeah. Mm-hmm. And in general, if I have a chemotherapy and I give high-dose steroids, I will try to give the vaccine in a week before the next round, not at the same time.
Okay, then the last question or comment was by Mr. and Mrs. Betts. Coming out of the pandemic, do you feel that some of the changes recommended in order to simplify treatment generally, like hyperfractionated radiotherapy, should lead to some more general re-evaluation of our standard recommendations going forward? Or will we all just go back to doing what we did before? And I think this is exactly what I pointed out. So meaning that reducing neutropenia has always been a good idea. It's not an invention by COVID, and I think maybe it helps a little bit to how can I say, to streamline our treatment guidelines anyway. But it's something that we should maybe think about. That's true.
I fully agree. I think that it's not only in lymphoma, it's in all areas of cancer treatment. This has opened the eyes of many that some of the traditions might be revisited.
That is true, but on the other hand, there were a lot of prejudice. You know, when it started, that let's say the prejudice that cancer patients, as such, are more susceptible to infections. Are we really sure this could well be? Then it is also a bit unclear. You know, the unclear blunt statement that cancer, the risk is increased. So is it the cancer? Is it disease? Is the treatment? A lot of things which we don't really understand. Or do you disagree on that, Matti?
No, I agree fully with you, and. This was led basically by a paper in the Lancet from China with 56 patients, if I remember well. And that led to this assumption that continues to be vehiculated in many areas, and that, of course, is completely wrong. It's not the cancer. It depends on the specific patients. It's obvious that someone has metastatic cancer and a certain age is going to be at very high risk. But that is not true for a young lady who is under hormonal treatment for breast cancer.
I fully agree.
All right, we are hitting the end of our webinar. I think there are many other things we could discuss, but we got a lot of information from our panelists, and I would like to thank every one of them. And you will find, again, their slides on the SIOG website, and feel free to contact them. They are all SIOG members. So if you are a SIOG member, you can find in the membership panel their email and send them questions and information that we can keep treating well our patients in this time of COVID. Thank you very much for all your attention.
Thank you very much.
Bye-bye.
For all the panelists, thank you very much. Bye-bye.